Most of my experience with this product is in the knee. I've had some cases where I could have done it in the ankle, but the patient was kind of holding off. But we can talk about that. So, what are bone marrow lesions? You know, you can see them on MRI. Obviously, you don't see them generally on X-rays or on CTs. You can see them on MRIs. But essentially, a bone bruise. You see high signal on the MRI, T2, in the subchondral region. And it's just an area that the bone's angry. It's like sore. And the way I explain it to all my patients, it's like you've been punched. You see a bruise on the arm and you get punched, black and blue. It's kind of the same thing in the bone. And they can be lingering and they can be really painful. And the same within the ankle or the foot, wherever you have a high pressure area. Every time you take a step on that area, it hurts. Just like, you know, and I always say it's like your big brother punching you. And the only way to stop it is to have them stop punching you in that area. And they can develop into insufficiency fractures, and then sometimes you will see a collapse of the bone if it's bad enough. Like I mentioned before, they're visualized on MRI, T2 weighted fat saturated, or the stir image, and I have some pictures of that. But they won't appear on X-ray or fluoro in the OR. So here's some visualization. You can see, I think it's here, yeah. So here's a little bit of the edema, tibial edema. And some of the radiologists will describe it, you know, as a subchondral fracture or edema. But, you know, depending on, and if you guys look at do you guys look at your own MRIs? So, you know, they may call it edema, you may call it an insufficiency fracture. I think use with the patient. You know, we have the benefit of having the patient in front of us. But
could you just call it insufficiency fracture all the time for billing purposes?
I generally do.
Because I was just talking, you know, with Ryan this afternoon about it. Because it's really some level of fracture.
Correct. It's you know, it's a stress fracture, or you get a fracture right when you got hit by the car. It's still a fracture. It's just, you know, a little stress fracture you might not be able to see, more microscopic. Where you get hit by a car, it's a falciform fracture. It's the same thing. It's a fracture. It's just the level. Correct. So I always say insufficiency fracture. That's the way I describe it. You know, some of the radiologists, you know, may say, you know, one of the ATFL is sprained. You look at it, no, it's torn. I mean, you know, you can tell you're examining the patient. There's no way it's just a little sprain. It's definitely torn. You know, like I said, as a radiologist, he doesn't have the benefit of visualizing the patient. So here's a talus with significant edema, and then on this other view, you can see it up in the tibia. So that would be very painful. And sometimes these are associated like with an ankle sprain. Kid comes in with an ankle sprain, you're like, you know, we'll send you a therapy or get better in 2 weeks, depending how you treat it. I'm very aggressive in therapy. Some people are, some people aren't. You know, I have partners that never use therapy. I use that on everyone because they do sports. People want to get back to an active lifestyle. You know, I treat active people. You know, not just someone who's 15, but I could be an active 70-year-old. You know, they want to get back playing golf or whatever they like to do. I want to get them back. So this is a great thing for these patients. But so this patient may have an ankle sprain and it's lingering. They come back in 3 months and say, my ankle's still bothering me. My ankle shouldn't be bothering you. You know, even a bad ankle sprain, I'll definitely get an MRI without question at that point. What happens to the bone marrow lesions over time? They get worse. You know, and you keep walking on it, and I always look at the floor. If the undersurface of this floor, the supporting structure of this floor is weak, the more you walk on it, you're going to get collapse of the floor. So, you know, the patient has increased pain. Like I said, you may think it's an ankle sprain or a tender, you know, capsule in the ankle or in the foot, but you got to always keep this in mind. And with time, the area grows. You know, so if you had an MRI at point times 0, and in 3 months you get another MRI, I guarantee the insufficiency fracture edema will increase. We see that. You know, patients who had an MRI, you know, a month, you know, 3 months ago, and they come to me and it's worse, we'll get a repeat MRI. You'll see it's worse. And, you know, there's the meniscus. And you can also see that, like my experience is in mainly in the knee, but in the knee I scoped and I thought it was just a meniscus. maybe trim the meniscus. If the patient comes back and they're still having pain 3 months later, we'll get a repeat MRI, and maybe it'll say questionable new tear, and the pain's really not in the joint, it might be more on bone, and before I started utilizing this product and thinking about it, I would say, I think you might have a new tear. I'll go in there and it's really not a new tear, and then the patients never get better. Inject the knee, I do a bunch of stuff, and voodoo medicine. It doesn't work now, and I'll show you more about this product, but I think this is a good solution for that. So you have to think of the bony problem, not just the joint problem, whether it's the ankle or the foot or the knee. And the evidence does show that these areas get bigger, and it can lead to osteoarthritis. If the joint surface area isn't supportive, the other areas have to support. If it's too much pressure in one area instead of dispersing it, can lead to more pain and osteoarthritis. It can also be associated with increase in joint replacement, whether it's the knee or the ankle. So what are the implications? This is a big finding on MRIs, as we mentioned, and that pain is definitely associated with these lesions. That's without question. And as the increase in the lesion, the increase in pain. They can occur anywhere, any loading surface. I see it, like I said, in the knee. You can see it in the hip. I don't have any information on the hip, but I see it in the knee. I see it in the ankle. You see it in the foot, anywhere there's stress. So talus, the proximal or distal tibia, proximal or distal femur, obviously the metatarsals, humeral head, vertebrae. They do the vertebroplasties. The spine guys have been doing that for years, and they're still doing it in patients with pain relief. So anywhere there's subchondral bone, this definitely has a benefit. And obviously with the knee, and same with the ankle, if you have a flat foot deformity, you're going to stress different parts of the ankle joint. And same with the knee, a varus knee, valgus knee, you stress different portions of the knee, medial or lateral. So we see it on there. So traditionally, when I would see a patient, and same with the ankle, but in the knee, patients would have some knee pain. And I get an X-ray, and if it's a kid, 15-year-old kid, comes in with knee pain, he's got joint pain, I'm going to get an MRI, I'm worried about a meniscus tear. But I think the more difficult patient is the patient with arthritis. And I would never get an MRI, and I actually would, the family doctor sent the 80-year-old lady with arthritic knee to me and had an X-ray and MRI, I'd be like, why did they get an MRI? It's arthritis, she needs a knee replacement. That was just the go-to answer. But now I've looked at the MRIs more critically and where the patient's pain actually is. Some of them have knee pain, some of them have tibial pain or femur pain, and that's different. They're sore on the bone, and they'll even tell you, I know my arthritic pain. This is different, doc. My knee has hurt for 10 years, but this is a new pain over the last 2 weeks. It's miserable. So we'll put them on anti-inflammatories, and they're not allowed to be on them because they have cardiac issues, and I still put them on it. We all do that, or I do it. You don't want to keep them on narcotics, and because that's bad for everything. We have cortisone injections. We use the Suparts injections or other hyaluronic acid injections, and that may give some relief. In the knee, I'll inject that point of tenderness. If it's on the medial sides, that's where the hamstring's attached. So that's like the pes anserine region for your anatomy. But and they'll sometimes get some relief, sometimes they won't. We'll get the compounding creams, we'll rub that area. That feels good, get them into some therapy. And then the best one, well, I'll skip this one first, but you'll do a scope and a microfracture because you think that's where it hurts. And you'll keep a microfracture, drill holes in the bone and keep them not weight bearing. And 6 weeks, you let them start weight bearing, a little bit, it still hurts. And you get the repeat MRI and it looks like it may be a change. So you go back in there and it's just a vicious cycle, and they hate your guts, and they go see someone down the road, and then we lead to a knee replacement, and maybe, and then the worst one is this one, is the non-weight bearing. Okay, non-weight bearing for 6 to 8 weeks. If you're a 50-year-old guy and you got 2 kids in college, and you got a job, and it's hard enough to get a job, and you tell a guy he can't work for 6 to 8 weeks, you can't do that. And then he's buying drugs off his neighbor who just had surgery so he can keep working. So this is a big one, and this is the reason I really got interested in it, and I've been very, very happy with it. And I've done about 30 of them, and we'll talk about it. So this injectoplasty, and it's a procedure, we're going to go through that. But when you have a lesion, you have this edema, the undersurface of the articular surface can't support the joint or the bone, like whether it's like a metatarsal stress fracture. That area is weak and it needs to have support. And that's what this provides. It's a tricalcium phosphate which is injected into that area. It's very simple, which is the great thing about it, but it also works pretty immediately. And then that converts to hydroxyapatite in over 24 hours, right? It's solid. So you get your MRI, and this is done in the operating room. You get your MRI and you look at all the views, sagittal, coronal, and axial. And I recommend taking your MRI into the operating room so you can look at it. And you're going to use this trocar. And you're going to, we used to drill it into the bone, but I think because of the heat, it's just not a good idea. And it's pretty easy. The trocar is sharp and it's easy to get in there. So you're actually just putting the trocar in, the inner portion comes out, and your assistant, hopefully, will mix it on the back table, and you're going to inject it in there. And it's going to fill up, and you will see it. So I will use, when I'm doing a knee, I'll have a scope in the knee, looking inside the knee, at the same time I'm injecting that under fluoro. And you can see like a shadow where it's filling in. And it's pretty cool because it matches your MRI. And that kind of tells you you're in the right area.
So you're having fluoro, arthroscopy, and injection at the same time?
Yeah, and it's real easy because the cameras in the knee, or the scopes in the knee, or the ankle joint, so that I can make sure, because if you have a subchondral fracture and there's a crack on the floor, the substance can leak through. And we'll talk about that, but I've had no problems with it. I just clean out the joint and I haven't seen anything, and I know other people have done these too, haven't had any issue. But I like to visualize it to make sure. And then you fill the void, and within 24 hours it hardens. And it's like cement. Now, the way I look at it, it's like a scaffold your body builds on. And I don't know if the science specifically, but obviously with all that fluid there normally, this substance kind of pushes that fluid out so the body can build there. And I think that's the great part about this substance. So this is the chemistry behind it. And there's other products out there, and I've used several of them, but not for this specific purpose. Like if you have a distal radius fracture in an older person. But this works very good. It's easy to use through the syringe. And they're working on improvements on it right now. But I've had no real issues with it. I'll talk to you about a few, but nothing major that would stop me from using it. But it provides a support to the area, to the undersurface of the cartilage, and then the body's able to remodel to normal bone. And like I said, you can see this on the fluoroscopy, the shadow. I have not had any repeat MRIs, but I'm sure there are guys that have. It would be a good study to provide. But here's a case study. 56-year-old female, felt a pop, having progressive pain with weight bearing. Pain is medial and posteriorly. Obviously, you're thinking of meniscus, but at the same time, where pain is a little distal, maybe not meniscus, maybe joint. So she also has RA and she's fibromyalgia, which is always a mistake. So she's got some swelling. Her pain is medial and over the tibia, which is important. She does have a positive Murray, which makes me think of meniscus, but her ligaments are stable. And here's her X-rays, and they're essentially normal. Kneecap's normal. And then here's her MRI. She does have a Baker cyst in the back of her knee, but that's not bothering her. But you can see here's the femur, here's the tibia. You can see a little bit on this T1 right here. But as we go further, you can see it right here. She's got a little meniscus tear right here. And that's where she points her pain is clinically on physical exam. Here's some more. So our plan would be an E-scope, partial meniscectomy, and then we would do the injectoplasty. I do the supine. Sometimes I'll do a block, sometimes I don't. It does help with the pain. I always use fluoroscopy. You don't have to use a tourniquet. And really, the injection part, I'm adding knee scope plus injection, that's including the mixing on the back table, everything, 30 minutes or less. If I didn't scope the knee, literally 5 minutes. So this is her knee, and she actually has a pretty bad knee. So she didn't have pain before, really, but that's all, that's bad cartilage. I mean, there's a normal side or lateral side, there's her medial side. I mean, this is bad. I mean, just cleaning this out probably isn't going to help her at all. I have patients like that, you go in there, it looks like this, that's bad, there's nothing you can really do for that. I don't know if you ever help those patients or not. But this is the trocar being introduced on the medial side and just injecting it. So I'll check an AP and a lateral, obviously, make sure I'm matching my MRI. And if you look at your own MRIs, it's easy to do. But I let them weight bear right away. Sutures out. Pain's better immediately. Generally no swelling after about 6 weeks. So from the procedure standpoint, I think it's really important to have your MRI, know your MRI, have it available in the OR, whether it's on your computer or you can get it from the hospital. I have all my stuff on my flash drive. At my office before my surgeries, 2 days before they put them on my flash drive. Start slowly, meaning you got to make sure you're set. You don't want the stuff to be hardening before you have time to get it going. So make sure the person on the back table knows what they're doing. And, your reps or whoever. It's pretty simple. It really is. I mean, it's even getting simpler now, right, Mark?
Yeah.
So it's not rocket science, but just make sure your timing, because it's getting hard. You don't want to be injecting. It's already hard, and you're not going to be able to do it. So make sure your assistant's familiar with the steps. Make sure you're utilizing fluoroscopy. Like I said, I would penetrate the lesion horizontally at first, and then over time you can change your direction. And then arthroscopically, I always visualize, because some of that will leak into the joint. I've had probably 3 or 4 that have done that, because there is a crack in the bone. With experience now, I don't pressure, I don't just jam it in before I just jam it in and I'm done. Slowly do it, watch it, let it harden a little bit before you push, like maybe back out as you do it. Some does get in the joint, I just flush the joint and I've had no problems. Patients aren't complaining. The 3 that it's happened to, they're doing great. They're walking on it. One guy just did a couple weeks ago, he had a bad fissure. I mean, a lot of it was coming in, but you could see it fill that void. He came in 2 weeks after, no pain, ready to go back to work. He's like, I gotta get back to work. I'm having no pain. 0 pain from not even able to weight bear for a month. Be patient as you're starting it, and like I said, if they leak into the joint, clean it out. I've had no issues. I get an X-ray after a couple weeks when they come back just to make sure. On those patients, I've had no problems. Weight bear is tolerated. I've been a little cautious now. I'm being more aggressive, letting them, because you get a little lady and you're like, I don't know, I'm a little nervous. I don't want you walking on it for 2 weeks. They come in, they're walking on it. I mean, they're just gonna walk on it because they're not in pain. Obviously I use Norco for pain. The one thing I will tell you, and healthier bone, like your runners, they have better bone. The stuff doesn't disperse, so when you inject it, it's under pressure. So for a couple days, they may have increased pain. You may get a call at night and say, it's worse, doc. Just tell them to write it out for 24, 48 hours, that goes away. And I've had 1 or 2 like that, and
Is it then that maybe we should just don't inject so much substance?
possibly, but I've had after those 24 hours, 40 hours, they're fine. I just, they like, it hurts more, doc. So I just make sure they take their pain meds, but I've had no issues. Personally, I'd rather put as much in there as I can so that it's more structural support or strength. And I'll put them on aspirin. If you do a block, I make sure they, are protected. And sometimes, depending on their age, a walker or a cane. And then I'm very aggressive in therapy. I want them getting moving because these patients need to get back. But I think these are, whether, like we said, they're all stress fractures, they're insufficiency fractures, whether you call it stress reaction, it's kind of, when you get an MRI and you got a runner who's got medial malleus pain, you're worried about stress fracture, whether they call it stress react, whatever they call it, they're painful, they're going to keep running, they're ready for that marathon in October, and they got 2 months to train. I think this, honestly, they're not going to listen to you, they're going to come back and then they're going to mess up because now it's a fracture that needs to be treated surgically. Now you have a problem, but arthritis, in the ankle, for a lot of you, look for this bone marrow edema because I think it will decrease the need for joint replacements just because of that. That is very painful. These patients have had arthritis for years and just the last 2 weeks have made it worse. So I keep that in mind. I know I've used it in a patient I did a knee replacement in. I've injected that area afterwards. They're having some pain, and it took away their pain. I have an associate who did a shoulder. He was doing a shoulder replacement. It was a revision. Went in, the patient had a big glenoid void, and he needed to fill an area of it. He put that in, let it hard left. Came back 3 months later, and couldn't even tell where that void was. So I've thought some of my glenoids and some of the older patients that might have a big glenoid, but in the center it's void. Like when I drill or put a screw in, I'm not getting good purchase. I haven't had to do it yet, but next time I'm going to inject that area, wait 10, 15 minutes, and then I'm going to drill through or put the screw in and let it harden around because I think it gives that structural support, or the strength, I should say. And then I've even considered using it for, I do a lot of ACLs, revisions, and primaries in the area that, I have bone tunnels that from a prior need to fill. I think this would be an excellent product for that. So as mentioned before, these are just joint pain, whether it's acute or chronic, and I would always ask, if the patient says, I've had ankle pain for years, doc, but this is much worse. Keep this in mind. It can have associated pathology. It can have arthritis. It can have ankle instability, but like we showed that picture before of ankle instability, they had talus edema. That's a perfect candidate for this. I rule out infection. That'd really be the only thing, obviously, you probably wouldn't want to do that in. The written x-rays don't generally show the pathology of the problem. So an MRI is key. I always try to conservative management at first, or at least offer it, but most patients, I will tell you, want to do this. If you tell them this versus 6 weeks of non-weight bearing, they're going this right off, and it's easy. It's not difficult, and it works. So this is a 15-year-old ankle sprain. There. This is actually an associate. This isn't mine, but they're putting in the trocar and injecting it. These are the coding for the knee, but I always use arthroscopic assisted, and you can code fluoroscopy. Or, we may have to look at, it may be an unlisted code for some of the stuff in the foot. I'm not sure about that.
So you're definitely coding for fracture.
Yes.
You're definitely coding for
fracture. You have
for
to.
anything,
right.
Marrow, edema, or anything like that.
Correct. I think you have to.
Yeah, because there's a code for that. Right. It's just like you said, it's an insufficient type of fracture. We always are afraid that medical is going to come after us.
Everyone, yeah. They will eventually, everyone.
But it's a fracture. So it's not really normal bones. It's not normal bone. It has to be
So, this is just the future. I think long-term studies need to be collected, but I definitely think it can delay total knees, and it has from several of my patients, who considering it said, I want to try this. Because you get a total knee or a total joint, that you have limitations. This you can continue doing